join to me to welcome Dr. Professor James Mayer.
Thank you. Thank you. Thank you very much for the kind introduction. I'd like to take a minute to thank the conference organizers, Mr. Chairman, and of course, ladies and gentlemen, for coming this afternoon. The topic of my presentation is expanding the scope of aligner therapy. This morning, Dr. Gardner mentioned, not too long ago, we thought the concept of digital clear aligners was very limited in handling relapse. I'm going to show you an avenue of treatment that has not yet been discussed in this Congress. This is where I'm from. This is a quiet little city called Las Vegas. And this is wintertime in Las Vegas. We get snow in the nearby mountains. And this is where I work, in the orthodontic department. We're one of the few universities, and perhaps the only university in the world, where we have a casino. There is active, ongoing research on gaming. The students invent better games, and I call it better ways to take your money. Disclosures up first. As it was pointed out, I consult for companies like Allergan. More recently, I am working as the Chief Technology Officer for ClearCorrect. And when we talk about a lot of material this morning, I've identified some common threads. One of them is we understand that there's many potential treatment plans for a patient. Really, a lot of this is still up to the expertise and the skill of a clinician. It by no means is what we call autopilot treatments, where it's determined by a company. And that's one of the prevailing themes that we're hearing. The other one is to have more tools. As an orthodontist, and to be able to handle the diversity of patients, you need to simply have more techniques available to you. And that's what I'm going to talk about. One of the things that is not a very popular topic at many conferences is how do you get out of difficulty? We all have seen those patients. We rarely read about them in journals, but you know the options sometimes are quite limited. You could quit early. Early deband is one of them. Another one is maybe the patient is not for your office. You can transfer the patient. Sometimes, and we've had to do this, although it's uncomfortable, you simply dismiss the patient. And the last one I call is geographic success. What I mean there is either you move or the patient moves. That's going to be success. But I think to add to your toolkit, one of the things that you can think of is a combination of fixed and aligner treatments, kind of a hybrid, another theme that we've heard of. And I will show you 3 patients that fit in that category for different reasons. This is the type of patient where, some patients, you just don't enjoy treating them anymore. They come in, they are poor compliant, oral hygiene is atrocious, and breakages, it's a long list. And you all know the face of these patients. You see the name in your schedule, and it darkens your day. And this is one of those where you're not quite finished, but this is one that is now set up for space closure. Unfortunately, we were able to finish her in using aligners as a way out, because the other thing is, in patients like this, unfortunately, when they're poor compliance issues, caries, decalcification, it looks horrible at the end of the treatment, and suddenly you have the tremendous guilt to think that you were part of it. So the sooner you can get out of fixed appliances, the better you are. And unfortunately, in the United States, we deal with a lot of litigation, which also adds more weight to your shoulders, is perhaps someday the patient or will get some poor advice from an attorney and come after you for the damages associated with orthodontic treatment. And we mentioned apical root resorption this morning. All the wealth of the studies show the number one indicator of whether or not a patient will get apical root resorption is the duration of treatment, above all. And I think about this when we have patients that run into treatments that are 3, 4, 5, 6 years, the odds are against you. This is another one that's difficult for another reason. She has a complicated movement here. If you look at the maxillary arch, you'll see that there's a rotation. Certainly, you could do that with aligners, and we have this adage that you can dig with a spoon, but you probably want to use a shovel. It's that kind of approach is you are all have access to traditional orthodontic biomechanics to perhaps use something that's more efficient than a aligner, get that done, and then next thing you know, the premolar is rotated sufficiently enough so that you can go ahead and complete the treatment with your fairly routine aligner therapy, like this. So that's another situation. And then what about these patients that are most difficult because the craniofacial anomaly with cleft palate? These cases have tremendous complications in the long run, and all the while we're with this patient for many, many years, meaning 6, 7, 8, 9, 10 years. And this is a patient that started with us, and of course we went the fixed appliance route. She had a lot of surgeries, not just dentally related, but throughout the body. She had, heart surgery. She had surgery for the calvarium. She had almost a dozen surgeries, plus the ridge augmentation and the orthognathic surgery we had. And, we did our best with orthodontics. Finally, she was finished to the point where there was, perhaps less than ideal restoration here. They couldn't, after several bone grafts, they couldn't, completely fill that in. So she has this unusually looking pontic with a little bit of pink on it. But nevertheless, we thought that was the end of it. Well, as time will tell us, it wasn't. We still have continued growth and surgical relapse. And these are tough patients. How many times are we going to put them in orthodontics, and how many more surgeries can this patient endure? And she became very aware of, small spacing, and that was a concern here. So she was the type of patient where we finished her, out of all this, even though this implant exposure looks atrocious, she was mostly concerned with some lower incisor spacing. And so that was a way out for us, that we could still continue making her happy. And that's what it's about with craniofacial patients. We have to understand we may not get canine class 1, ideal overjet and overbite. You simply help the patient cope and manage through life. And I think that leaves an area for aligners to help out. So this whole topic of combination treatments is ideal to help fill in the orthodontist's armamentarium. And the combinations are as wide as your imagination. And I think part of this is we talked about this morning, mentioned also treatment efficiency, try to reduce the overall time in all of fixed appliances to reduce complications. And of course, we're now enabled by many of the technologies that you've seen in the speakers this morning in their presentations. And one of the latest technologies is simply to digitally remove brackets and then go on with the aligners. So you now have the option to, before treatment starts, to pick which phases of treatment that you choose to do aligners as opposed to fixed appliances. And with digital systems, it makes it easier for one to transition back and forth between fixed appliances and aligners to be most efficient and to reduce the number of complications with orthodontics. The other part of my presentation this afternoon is to talk about another spectrum of our treatment group, which is early treatment. The reality is this, and sheer numbers of participants in this Congress alone is a testament to the popularity of clear aligner therapy. It really is the next chapter in all of orthodontics. I look around, and I'm in the convention capital of the world. We have probably 1 or 2 orthodontic congresses in Las Vegas every year. I see these congresses that used to fill 1,000 people, orthodontists, in a room for a particular fixed appliance technique. Their attendances have diminished to about half across the board. Doesn't matter which appliance system. But then I see what's happening with aligner congresses, and they're oversold. And that seems to be the trend of the world. It's appealing to all types. Another thing we have to look at is the largest treatment group in orthodontics is children. Simply that. But children have different types of problems, meaning that you need to have a variety of appliances and mechanics to treat these children. And my own philosophy is I try to keep things simple, the KISS principle, to decrease the in vivo inventory. I've seen very complex biomechanics, and there's numbers of brackets and wires, auxiliary wires, et cetera, in the mouth, well, all those things give a bigger chance of breaking and more emergencies. I like to decrease emergency visits. I also, one of my goals is to decrease the phase 2 treatment time and increase overall treatment efficiency. And of course, and you're aware of this, younger patients are entering your office asking for aesthetic treatments. So what I'm going to describe in the remainder of the time I have is 3 appliances for early treatment. One is a class 2 corrector, one is a headgear or class 2 and class 3 corrector, and the other is an expander. The first one I'll cover is a jaw repositioning appliance for correction of class 2. And this is just a schematic of how it works. It's basically a twin block, but it's manufactured to be aesthetic. So you have an upper component and a lower component. The upper component has a block, as does the lower, and you can see what happens when the two meet in occlusion. Because of the block design, it simply advances forward like this. And you can see what it does to reposition the mandible forward. So we have a young man here, and if you look at him, he's facially a little bit convex. And here he is pre-treatment. And this is the appliance that you see on the right side of the screen there. I admit it's not very professional because I made it. My lab does a much better job now. But what you see there, it's simply a thermoform appliance, and you have the twin blocks on the buccal surfaces of the teeth. And you can see a better view here of what those elements look like. But also take note that up here, because it's clear you can't see it, there's a headgear channel here. So it becomes a combination appliance. It has the functional appliance effect, but also I'm using headgear with it as well. And so here he is, appliances in place, and you can see the immediate change in the profile and pre-treatment 3 months later. And like many of the removable appliances, it's subject to cooperation. So we go through that as with bite planes and headgears and so forth. He was a very good patient, so we got really good results with him. And here we go on to more correction. There is some steps in how to register the bite, and the nice thing is because these appliances you can make them or have your lab technician make them, they're very, very inexpensive. You can make several bite registrations, so if you want to advance the mandible 2 to 3 millimeters at a time, that's completely up to your option. There's no limit, and they're very low cost. You simply set different bite registrations for him. The other one is a class 3 appliance here. And the other thing that is most frustrating with class 3 patients is you're with them for a long time. Of course, you want to try and do something orthopedically, around age 9 or so to start things going, but then suddenly you're going to be waiting until the permanent dentition and any residual growth occurs. So I'd like to keep them out of fixed appliances if at all possible. So this is simply a thermoform appliance with hooks for it here. You can see it there. And this is going to be used with the reverse pull headgear. And the patient's wearing it pretty well here. And appliance insertion, and 2 weeks later. And we use very heavy elastics here to the reverse pull headgear. The other one is the expander. And again, this is the early prototype I made, so it's kind of rough. But the idea is you have your conventional expander here, and this is simply orthodontic acrylic, and this is a thermoform material over it. And here we have a typical young patient that she needs a little bit of arch development, arch preparation. And the way I think about things now is when it comes to clear aligners, your sequence is a little bit different. Arch preparation, AP, and expansion before you get to the details as far as rotations and alignment. But anyways, we made this for her, and note that it covers all the teeth. You get incredible anchorage when you cover all the teeth plus the palate and even the incisors. So we do a cut here, and there's I simply use a quarter turn every 2 days, And when I have enough expansion, I use crown and bridge scissors, and I cut out the front, and I let the transeptal fibers do the work of moving the incisors back together. It's very straightforward, and you need to tell the patients to expect a maxillary midline diastema. Indeed, that's how you know it's working. And once you have enough expansion, just cut it in the front, and section of the tray removed. You can see the separation of the left and right side of the expander, and that's exactly the amount of expansion that you get. And then the patient's now ready for the rest of her treatment in aligners, and that's in fact what we did. We did the finishing in aligners here. So basically, this is many of these appliances are really straightforward. You start off with a traditional impression. I do need to point out, though, to get the rigidity for expander, you have to use thicker material. Traditionally, our aligners use the 4 mil or 1.0 millimeter thickness. For these, I'm using a 6 mil or 1.5 millimeter thickness material. And another little trick is to incorporate the expander with the acrylic. The orthodontic, the expander is put on the stone model, and of course you have to block out the screw, but then you thermoform over the acrylic, and it leaves a much smoother surface for the tongue. And again, I expand at 1/4 millimeter every 2 days. After 3 or 4 weeks, or whatever amount of expander. Of course, in large expansion cases, you may have to do more than one expander, but that's up to you, and there's different sizes of expanders that you can purchase as well. So allow 2 or 3 weeks for the midline gap to close, and then you just do another impression and a retainer here, and retain with the thicker stuff here. And then we get into phase 2. Another nice thing quickly is these are very retentive. You may not think that these appliances are retentive, but you can even have a class 3 patient where a lower one, this is an upper and lower, and you notice what's going on here. There's hooks for the headgear, or the reverse pull headgear here, but intraorally, she has class 3 elastics. And so these patients are managed with no brackets in their mouths at all, with very inexpensive appliances. But the most important thing to this patient is they were aesthetic. She didn't even bother or was too concerned about wearing this at night. The most important thing for this patient is during the day, she thought she had aesthetic appliances. And so that's a big win for me when I can encourage cooperation and success from our patients here. So basically, the advantages are it's really simple. It's aesthetic, they're clean, people take them out to eat, and they obviously can brush and floss as they normally do. You don't need to band, so think about eliminating the separation appointments, the band fitting, and all that stuff. If I know I'm going to do it at the records appointment, I just take an extra set of impressions, and also you can expand at any time. During some stages of the transitional dentition, when there's mobility of the primary molars, normally you can't do anything. But these appliances have so much retention, including all the teeth in the palate, you can just forge ahead. You've got plenty of anchorage for expansion. And like I said, it combines teeth and palatal anchorage. Another big advantage, particularly for parents, it's activated outside the mouth. And indeed, I've found, even in patients as young as 7 or 8 years old, they prefer to activate it themselves. I simply ask them to put a calendar on the wall, and now the parent doesn't have to struggle with the expansion screw that would be cemented in the mouth. And that's been also a big advantage as well, and it's really low cost. Big disadvantages, I've had patients that are not very cooperative. They do lose them. So the same vulnerabilities as you do get with removable retainers, it can be lost. It relies a lot on cooperation. And for the expander, just a little bit of a tip, you need to build space between the palatal vault and soft tissue. When you expand, the palatal vault comes down. So you need to separate and put a layer of pink wax there. Otherwise, it will impinge on the palate. So basically, that's my presentation for today, showing you some ideas for combination treatments. Oh, by the way, I know I had to go through this really fast, but the whole protocol for fabrication of these appliances And the material list and how to do it and the clinical utilization, you can download it. It's freely available from clearcorrect.com. You just go there and you can download it and you just register for it and you can get it for no cost. Thank you very much. Thank you. Thank you.